What is the risk of infection associated with BCMA-directed therapies? Why does this risk exist?
So what are the risks of BCMA approaches or BCMA treatments? BCMA is a marker on the plasma cells, and we see that the more aggressive or the more progressive the myeloma, the more BCMA we have on those plasma cells, and we have seen a lot of good responses to BCMA-based or targeted treatment. Now, unfortunately, almost all myeloma treatments attack all plasma cells. Plasma cells in our body are cells that help us fight infections. So we're giving a treatment that will not differentiate between a bad plasma cell and a good plasma cell. It will kill both. We end up in a situation where we don't have a good defense mechanisms. Also, for the new bispecifics antibodies or for the CAR-Ts, with the CAR-T we give large doses of chemotherapy, we kill the lymphocytes, all of them, so we can create a space for the new lymphocytes. For bispecifics, we're grabbing those lymphocytes in one hand and the plasma cells in the other hand and put them both next to each other. Means this lymphocyte is already occupied with another job, and they might forgo or overlook infections. This is very important. When we start treatment with BCMA-targeted agents, to me, whether it's CAR-T or whether it's a bispecific antibody, prophylactic antibiotics are very important. Actually, we have seen, we call it PGP pneumonia, and you don't have to remember the name. It's an opportunistic infection. We see that those cases of pneumonia tend to be higher in patients who don't get prophylaxis. And those are microbes that are in the air everywhere. We cannot, avoid them. Usually they don't cause infection. Why? Because our lymphocytes always stop them on the border. But after starting BCMA treatment, as we mentioned, the whole immune system is occupied. Then those germs or those microbes can cause problems and pneumonias. Giving Bactrim, giving pentamidine, among other options, is very important for those patients. In addition, we all know, all multiple myeloma patients should know this by now. Any treatment or the majority of the treatments go hand in hand with acyclovir to protect from shingles. Very few exceptions throughout the treatment course where we don't use acyclovir, so the default is acyclovir all the time. And if we have a pancytopenia, we always give antibiotics and antifungal, those to protect from actual germs in day-to-day kind of activity. Once the pancytopenia resolves, then we continue with prophylaxis, acyclovir, and for example, in BCMA-targeted treatment, something against PGP pneumonia. So the other role for plasma cells is to produce IgGs or IgA or IgM immunoglobulins. If we killed good plasma cells, then we will not have IgGs, IgA, IgM levels high enough in the blood. The most important of those is the IgG levels, which is they can protect us from infections. After BCMA-based treatment, with such good, effective treatments, we wipe out everything in terms of plasma cells. It's important to replace IgG levels with IVIG. We do it once a month. After CAR-T treatment, I like to monitor the IgG levels for the patient in the blood and make sure it's more than 400. The cutoff is also variable. For bispecific antibodies, I like to keep going with IVIG regardless of the IgG level in the blood, just to make sure we support the patient from infection.
Infections with BCMA therapies should be broken down into the mechanism of action of the BCMA therapy, whether it's a CAR-T, bispecific, or an antibody-drug conjugate. Probably from least to highest would be the antibody-drug conjugate is the least, followed by the CAR-T, followed by the bispecific. And part of that has to do with the fact that bispecifics are repeatedly targeting the antigen as opposed to CAR-Ts are done once. and then the antibody drug conjugates seem to be gentler. But the most severe case would be the BCMA bispecifics, which have a rate of infections of around 80%, and about 55% are high-grade infections, grade 3 or higher.